some research. Whereas for men, they experience a threefold increase in the likelihood of reporting a fall and high falls risk among compared to females. So some of the challenges around depression and anxiety are the lack of acknowledgement. So really not seeing that it's there and it's a problem. So in many cases, anxiety and depression are kind of swept away or attributed to being part of the normal aging process. So there's this assumption that older individuals, you know, well, a little bit of anxiety or depression is a natural part of getting older, and that's just the way it is. It's often not seen as something important for older adults. There's an assumption that for older adults, their physical health might be more important than their mental health, so it's not a priority for them. I suppose this goes alongside a tendency of older patients sometimes to minimize symptoms and to not give those symptoms the weight that they might otherwise get from a younger patient. And then I think a really big problem is language barriers. And by language barriers, I mean the language of our assessment tools. If we look in detail at many of the ways that we measure, say, anxiety or depression or quality of life and fear of falling, you can see that the language is often quite difficult, conceptually difficult, and it may not be the most suitable. So part of the work that the group that have organized this webinar are doing is trying to really interrogate the measures we use and make sure that they're fit for purpose with older adults and that they actually measure something meaningful. There are a lot of challenges in diagnosis, as any of you who are working in healthcare will know. If you go back to what I described as the physical symptoms of depression and anxiety, things like change in sleep patterns, change in appetite, loss of concentration, sweating, palpitations, these are all very real symptoms of many other illnesses. So it's very easy for these symptoms to be dismissed, or not dismissed, but reasonably be assumed to be part of another illness that a patient has. So it takes time to disentangle the symptoms. There's also a difficulty in distinguishing when it comes to anxiety between that which is adaptive and that which is a problem. And what we mean by that is that when somebody's diagnosed with an illness, or even when somebody has a fall, there's a certain amount of anxiety that's a good thing. So it's a little bit like sitting an exam. It's a good thing probably to be a little bit anxious about that exam because you study harder for it. The same is true when somebody has to change their routine. When somebody's a little bit anxious, it may make them more aware that they have to do things differently, that they have to maybe have a different physical activity regime, a different eating regime. So we would call that adaptive. On the other hand, pathological anxiety, or anxiety that is not helpful, is that which persists independent of how your illness is progressing. And distinguishing between those two is difficult and takes time. And again, while the language barrier is an issue with assessment tools, the other aspect of a lot of assessment for mental health is that it depends a lot on memory. So I mentioned that in order to have a clinical diagnosis of anxiety or depression, your symptoms need to persist for at least 2 weeks. Now, I don't know about any of you. Could you remember what you did 2 weeks ago in detail if I asked you? I know I couldn't. And I think sometimes the tools that depend on memory make it difficult to do an accurate assessment, particularly in older adults. There are treatment gaps because we don't do enough of screening. And partly we don't do enough screening because there's not enough services to refer people to. Now, I would argue in general when it comes to mental health, and Darlina, who's presenting the slides, is a clinical psychologist, and I'm sure she would say exactly the same. We don't have enough psychologists and psychiatrists to begin with, but we really lack specialists in the area of gerontology in this area. So it's something that is a gap. Okay, so let's look briefly now at quality of life. And I suppose if we look at where we are with healthcare, just that last bullet point there, we have become really expert at adding years to life. So we can keep people alive for longer with many different interventions and wonderful advances in healthcare. But what's important is that we're adding not just years to life, but life to those years, and that people have a reasonable quality of life while they're living with their medical interventions. And this is part of the growing interest in quality of life and how we describe the quality of life of populations. It's important that we're able to characterize this. It's important that we're able to assess the impact of illness, like a fall, on individuals in terms of the impact on their quality of life. And it's really important that we're able to evaluate and compare health interventions, because if you have two interventions that are perhaps very differently priced but have the same effect, you might look at the impact on quality of life as perhaps a deciding factor in deciding which one you should use. There are lots of definitions of quality of life, and none of them are simple. They're all quite multi-layered. But I suppose the main things to highlight is that quality of life really is what the person says it is. Quality of life is an individual's perception of where they are in their life and where they are in relation to, I suppose, where they want to be, what was their goals and their expectations and their standards and their concerns. So it's not just about your physical health, and it's not just about your mental health. It's about a whole range of things, ranging from physical, psychological health, your independence, your relationships, and where you are relative to your environment. So quality of life is associated very much with falls and fear of falling as well. So we know that as people are more fearful of falling, quality of life decreases. Quality of life decreases after a fall. And we know the poorer quality of life is associated with a higher risk of falling. There's also a significant association between fear of falling and depression and quality of life. So this again is a kind of a complex relationship where fear of falling increases depression and depression decreases quality of life. So one of the challenges around quality of life assessment is that when you look in particular at older adults, how severe their symptoms or disability is not a consistent predictor of quality of life. So what I mean by this is if you talk to older adults who are unwell to varying different degrees, you will often find somebody who is very unwell, but who will say, you know, I'm doing good. I have a good quality of life. And then you have people that have less symptoms, but feel like they're not doing well at all, and they would report their quality of life as poor. And this is a challenge because when we measure quality of life and health-related quality of life in particular, many measures just ask people to list their symptoms, and they add up those symptoms and conclude if somebody has a lot of symptoms, then their quality of life is not good. And that couldn't be further from the truth for older adults. Which means we can't simply use the measures that we would use with younger populations with older adults. Okay, so finally, we're going to look briefly at fear of falling. Fear of falling, again, the prevalence ranges widely depending on your sample and depending on the measure that you use. What we know is people get more fearful of falling as they get older. And fear of falling does not depend on having had a fall. You can be afraid of falling whether you've had a fall or not. What fear of falling does, though, is it makes you really avoid activities which you think may increase your risk of falling. So people tend to act in very safe ways, and some of this could be very appropriate, but some of it could be cautious. So falling to fall with self-efficacy is my confidence in my ability to prevent myself from falling. So if I have a very low confidence in my ability not to fall, then I have generally very high levels of fear of falling, and I'm more likely to fall. So it's essentially almost a self-fulfilling prophecy. It's also associated, fear of falling, with anxiety and limited activities of daily living. So what can we do with all of this information about the psychological well-being of older adults? Well, the first thing to do is we need to acknowledge the fears and worries and not just sweep them to one side. And we need to do full psychological assessments. Now, these don't take long, and you'll see some of the tools that you've been sent and that will show you. These are very quick to administer and how somebody is doing psychologically. The second thing to do would be to set small, achievable goals. This builds self-efficacy for the older adult and helps them to feel more in control and then less fearful. Making plans for them, active plans for them on how to prevent falls, so who they can get help from. It's really important to work with family, because family may think they're doing the right thing in restricting the movement of their loved one, but that actually might not be the best thing at all. And getting the family involved in looking at the environmental and health risk factors in the home in particular, because we know that that's where most of the falls will happen, is really important. Because ultimately what we're trying to do is to keep older adults independent and active for as long as possible. This increases psychological well-being and has the effect of reducing falls, which is our ultimate goal. Okay, so Darlina is now going to talk a little bit about some of the screening and assessment tools that you might want to use.
All right, can you hear me?
Yeah.
Okay, great. Hi, everyone. My video is not on. Is that okay? I'll have to, hold on.
Working fine, I think.
Yeah, sorry, I have to jump here and there. All right. Can you see the screen, the slides?
Yep.
Okay, great. All right, so here's just the list of some screening or assessment tools that we can use, you know, to screen and assess older adults in terms of psychological variables like depression, anxiety, quality of life, and falls. So obviously this list is not exhaustive at all. You know, we just picked a few. And if you can see, you know, DAS21 is probably something that, you know, all of you are quite familiar with. You may have even done it yourself. Okay, so it's 21 items looking at depression, anxiety, and stress. For depression, we also have more specific ones, you know, for older adults. So you have the geriatric depression scale, the GDS, which has a long form and a short form, and then you also have the CASD. For anxiety, you have a few that I've listed there, including the GAS. Okay, then you have quality of life, which is the SF36 and the CAS19. And we also have the short falls efficacy scale international. So I think moving on, what we're going to do is I'm going to pick a few of these scales and tools, and then get you to sort of look at the items, okay? And then maybe comment and see whether, you know, are these items actually suitable for older adults? And whether, you know, they would understand it, it would make sense to them, and whether it's a good enough tool for you to assess, to screen and see whether they have any of these psychological issues. All right, so this might look quite small for you, but, you know, this is a DAS21, and basically what it has 21 statements, right, asking you to rate from 0 to 3, okay, on whether, you know, these statements actually applied to you over the past week. All right, so it's just, you know, you're not supposed to spend so much time on the items. Just read it and then just answer what first comes to mind. So what I'm going to do is, this is a bit small, so I've made it bigger, so we're going to split it into 2. So what we want to do is, this is the first 10 items. Now, because this is a screening tool to look at depression, anxiety, and stress, right? So if you just look through these first 10 items, can you actually identify, which one is actually asking a depression symptom, which one is asking for anxiety, and which one is asking for stress symptoms? And maybe, feel free to just, unmute your mic and just speak if that's more easier for you, or you can just write it in the chat at the side. So maybe just pick, one question which you think is depression, or which one you think is anxiety, which one you think is stress. Karen, because I can't see the comments, so you're gonna have to read it out to me.
Oh yeah. Yeah. Everybody's quiet.
Ah, okay.
Okay, so somebody says number 10 is depression, and number 2, 7, and 9 are anxiety.
Yep, exactly. Okay, that's fantastic. Okay, so 4 out of 4 correct. Yeah. Okay, so it's quite quite obvious, especially if you already know what are the depressive anxiety and stress symptoms, right? Okay, fine. That's fine. Now look through these 10 items and see whether it would be suitable for older adults to actually answer these items, and give it a rating from 0 to 3. Okay, I guess look at some of the items. You think it's something that, bearing in mind that this was not developed here, not developed for our community, whether they would understand, the statement or the words, the phrases being used here.
What about item 1? Does everybody understand that?
Yeah, I mean, if the items actually look, that you actually understand that, and you think somebody who has good command of English would understand that, then that's great. Then it's good. Then you can use it for, whatever population that you're doing screening for, whichever type of patients you're seeing. Okay.
We have a no and a yes.
Ah, okay. For item number 1. Yeah. Okay.
Yeah. What about number 7? Number 7 could be related to many different things.
Yeah.
One of the participants is just saying there's a Malay version. Yes, there is a Malay version. And one of the difficulties, and Darlina, you can speak to this as somebody who's translated many measures, is that it's very hard to translate some complex English words into Malay. Us English speakers have a tendency to completely overcomplicate things, I think.
Yeah, so I think one of the, if you look at number 9, I was worried about situations in which I might panic and make a fool of myself. Make a fool of myself in Malay, how do you say, memperbodohkan diri sendiri or something like that, right? But then it's not something that is quite natural for us to describe, maybe. Okay, so it's sometimes direct translation doesn't really work. So I'm going to show you the remaining 11. This is just the, showing which one is stress, anxiety, and depression. Now, this is the remaining 11. Okay, so if you look at same thing here, if you look at this item, is there any item here that, some patients or some participants might not really understand? Or you may even have trouble translating into another language.
Number 14, yeah. Okay, 17, yeah, okay.
Yep.
15.
Yes, yeah.
19. And
what,
somebody has made the important point that, you know, there's a lot of things here about symptoms that might actually be associated with other illnesses.
Yeah, exactly. You know, so basically anything that has sort of, if you want to put generally, the ones that have anxiety items, right? It could be related to something else altogether, some physical symptoms. Now, you know, you've all pointed out really, yeah, some items that can be quite difficult or to understand, but look at number 13, right? I felt downhearted and blue. Okay, I guess if you were to translate that, it's biru, right? Which doesn't make sense at all. And somebody who might be reading it quite literally, you know, it might not be as straightforward as we think it is. Okay, so we kind of need to be aware of the tools that we choose. Okay, whether it actually you know, is fit for purpose. Okay, so for the participants and for the, you know, the variable or the measure that you're actually trying to measure. Okay, so while DAS 21, sorry, okay, so that's again the you know, which one is stress, depression, and anxiety. Sorry, okay, so this is just another form where it's easier for you to just score. So if you look on the right hand side, it already has identified which item is for D, A, and S. Okay, so again, with DAS 21 is a very, very, very popular tool, right? And if you look here, this is basically the scoring table. So like Karen said earlier, if somebody scores a 0 to 4, that's great, you know, fine, normal. But you know what, you know, and once you're at 5 and 6, you know, you already, you know, you have mild depressive symptoms there already. So what if somebody is scoring at a 4 for depression, or 3 for anxiety, and 7 for stress? Do you just ignore them, or do you, you know, investigate further, ask further? So what do you do? Okay, so when you do, if you say you do use DAS 21, right, and say they score severe for depression, so what do you do? Say, well, thank you for filling in this questionnaire, bye-bye. You know, so when you use these things, while yes, it's very nice to see where they are on a scale for these symptoms, we also have to, you know, plan for, yeah, what if we have participants who score highly, you know, severe or extremely severe? It would be irresponsible for us to just ignore them. So we would need to, you know, have some things in place, you know, maybe a phone number that they can call, somebody else you can refer them to, and things like that, for patients who may score at a have higher symptoms of these psychological variables. Okay, so again, so DAS 21 is very, very famous, right? But again, it may not be suitable for the population that you're looking at. So, you know, you got to look at whether DAS is suitable for older adults. And also, if you look, it's looking at 3 different variables. So maybe you want to be more focused and look at a tool that only, if you're only interested in depression, then just look at a tool that only looks at depressive symptoms. Karen, do you want to add anything for DAS?
No, and I suppose we don't want people to think that we're doing we're being overcritical of the DAS. We're just using this as an example. It's certainly a very good measure, but I know that there's a tendency, and I have certainly done this myself in the past, of saying, okay, this is a measure that's well published. I'll use this in my study because it's well known and because I won't get maybe as many questions about my methods. But if we really want to get meaningful data about older adults in Asia, we've got to really try to think, is this the right thing to do? Because collecting lots of data is one thing, but getting meaningful data is more important.
Yeah, agree. Okay, so there's another tool. So we're not going to go through all the tools. In fact, if you look at the Google Drive link, which has been shared with you, all these questionnaires are actually in there. Okay, so this is another one. This is geriatric depression scale. This is a short form. There's the longer form. But this one is, again, you know, asking about your condition for the past 1 week. But this one only requests you to say yes or no. Okay, so if you look at these items, you know, is this an okay tool for you to use, or do you have any comments about this tool that you would like to highlight? Or, you know, try picking a couple of questions and see whether can you answer them or not.
So there's a comment here, Darlina, that number 8 and number 12 seem to overlap. Yes, and I think that's a really good point. And again, I think this is, again, where we get into trouble with translations, where there's subtleties of difference between items that get lost when you translate. So it's perfectly acceptable with many of these measures that when you actually are doing your data analysis, we actually drop items. So I'll show you that when it comes to the quality of life questionnaire. There's nothing to stop you from actually asking these questions, but if you think an item isn't functioning, or if it's not giving you a meaningful pattern of responses, just drop it and adjust the scoring as you need to. That's perfectly okay.
Okay. Right. I guess one of the critics of this scale is the fact that it's a yes/no question, and you very seldom that you can actually say yes, no to a statement when, you know, if you had a Likert scale type, or, you know, a range of responses, then that would be maybe more reflective of how the participant, the patient, was actually feeling. All right, so you have the CSD. You probably can't see this too clearly, but you know, I'm not going to discuss this. But basically, this is just another tool that you can also use to measure depression. And this is also you know, asking about how the patient felt in the past week, right? So this is the geriatric anxiety scale. Okay, so sorry if you can't see this. Again, this has been shared with you, but I just want to highlight, while, you know, this is an anxiety scale, but the items, some of the items are like, you know, I had heart racing, I had shortness of breath, I had an upset stomach. Okay, things like that. You know, you could argue that, hey, that could be related to a physical illness as well. But there's a lot of other things about concerns, about cognitive type questions as well, you know, which relates to anxiety. Okay, Karen, do you want to cover the SF-36?
So I suppose, yeah, this is an example of a very famous quality of life questionnaire, which I have to be honest and say I'm not a big fan of, but it's widely used. So you can see here that it really focuses on particular activities. So whether somebody can carry groceries, walk flights of stairs, whether they can bend, kneel, or stoop. So this is an example of a quality of life measure which is very focused on health and symptoms that relate to ill health. In comparison to, say, the CASP, which is one that we've validated for use in Malaysia as a CASP 12. This is a measure of quality of life that was specifically developed in the UK for use with the older population. And you can see that there's very little here to do with health. And what this measure gives you is 4 subscales: control, autonomy, self-realization, and pleasure. And each of those scales has a subscale score, but overall there's a score from 0 to 57 in the CASP 19, which basically allows you to see what people's quality of life is relative to others. So higher scores mean better quality of life. We validated this for use in Malaysia, but we removed some items that just didn't really work in the context of Malaysia. And I'm just curious to see if anybody could guess any of those items that you think mightn't work so well in the context of Malaysia. Anybody got any ideas about which of the subscales do you think might be less important in an Asian context? No, not self-realization. Yes, it is autonomy. And the reason for that, I suppose, is if you look at it, you have a difference really between a collectivist culture in Asia and a more individualistic culture in the West. And I think control is important in both. And I think that's really important. Control is a very important variable in both societies, but autonomy less so in Asia, and probably reflecting that collectivist environment. And as Maupin said, the fact that families tend to live together and work in a more collaborative way, perhaps. So, I mean, this is just one alternative way of looking at quality of life. We're not saying it's the best way by any manner of means. I think if we, just to wrap up and to make sure that you get time for a break before the talk at 1, I suppose what we're saying here is that the relationship between psychological well-being, quality of life and falls is complex, but it's really, really important. And psychological assessment is an important part of assessing a faller. It doesn't have to be complicated. It can be a few short screening tools. So going back to what Darlina said, if you did the DAS with somebody, if that was just the only measure you had, and somebody scores 17 on depression, well, at least then you know you absolutely have to get this patient to a clinical psychologist or psychiatrist for a full assessment quickly. It gives you something to work with. And I suppose you should consider your measurements carefully. What is it you want to measure and why? And then choose your measures appropriately. So I think we can leave it there unless there's any other questions. Obviously, if you're involved in psychological assessment or you want to know anything more about it, we're happy to send you measures, send you any papers that you might want. Just drop us an email. We'd be happy to get back to you.
Yeah, and I guess in the Google Drive, you also have the fear of falling, the FES tool as well. Yeah.
That's a really short tool. It takes minutes to administer.